Welcome to Skin Conversations, a podcast brought to you by St John's Derm Academy, where we share stories about skin science and the doctors and individuals who shape dermatology.
So hi everyone, I'm Dr. Ali, a consultant dermatologist, and I'm also lead for digital education at St John's Derm Academy.
And I'm Dr. Beibei, also a dermatologist and skin researcher working as a clinical lecturer in dermatology. This podcast is our way of opening up the conversation from the laboratory to the clinic and, most importantly, to you. Whether you're someone with a skin condition, a healthcare professional, or just curious about the science of skin, you're in the right place. From eczema to acne, pigmentation to psoriasis, we'll dive deep into the conditions that affect millions and the research that's changing lives.
So we believe that by opening up these conversations about skin, we can empower our listeners with knowledge, debunk common myths about skin, and shine a light on the vital role of science in advancing skin health.
So, wherever you get your podcasts, hit subscribe and join us in the skin conversation. Hello, and welcome to today's episode of Skin Conversations. Today, we're going to be talking about the evolving landscape of psoriasis care. Over the past 10 to 15 years, psoriasis treatment has undergone a remarkable shift. We've moved from simply managing symptoms to embracing precision medicine, using targeted therapies based on our understanding of the disease's molecular and immunological pathways.
Joining us today are two of the foremost experts in this field. We have Professor Catherine Smith, a consultant dermatologist and Professor of Dermatology and Therapeutics at St John's Institute of Dermatology. Her work focuses on translational research and improving outcomes for patients with inflammatory skin diseases. We also have Professor Jonathan Barker, a professor of medical dermatology at King's College London, whose pioneering research has helped shape our understanding of psoriasis pathogenesis and treatment innovation. So together we're going to be exploring how far we've come, where we're headed, and what it means for patients and clinicians caring for patients with psoriasis.
So, to get started, I'd like to just go down memory lane with both of you because you've both been at St John's for a very long time.
Long time.
And I remember you telling me, Catherine, around a year ago about how when you first started working at St John's, I believe it was as an SHO, which is a very sort of junior doctor role.
Yeah.
One of your tasks involved sweeping up psoriasis scales.
Mm.
And so I just want you to reflect on what your day-to-day life as a dermatologist, as a junior dermatologist, was like then, and what you thought psoriasis was as a skin disease at the time.
It has changed so much. But yeah, well, as a junior doctor and SHO, first of all, we had a ward of around 60 patients, and that was part of my job to look after people on the ward. And the vast majority of those people on that ward had psoriasis. So people with psoriasis would come in for 6-7 weeks at a time, be covered in creams and ointments, and spend the day in bandages. And that was your job to, look after those patients. And patients would then be discharged for a while and then put back into outpatients, and then they'd go through another flare. And in all the outpatient clinics, we had those hoovers on the wall, because when people came into the room, they would come in and you'd have a look at their skin, they'd get undressed and then leave skin all over the floor, and it was awful, terrible for the patients. I mean, it was so awful and stigmatizing and humiliating, and that's actually why we brought the hoovers in, to try and manage that and remove that embarrassment for people, because they were conscious of having left their mark in the room. So it's transformed out of all recognition, and people with psoriasis then had really very, very difficult lives, and we had very limited tools for managing it. So I think it was difficult, actually, because you had this disease that we knew a bit about the genetics. Jonathan can talk about that much better, but really why they were getting that problem, what their prognosis was. Your main tools were creams and ointments, and then methotrexate. Yeah. Very different. Very different.
So, Jonathan, do you want to talk to us about what some of those key scientific breakthroughs were?
Yeah, well, as Catherine says, I mean, it is unbelievable how things have changed. I started my dermatology training in 1985. And as Catherine points out, we had 60 inpatient beds at St John's, 60 inpatients. The life of a junior doctor, and indeed a senior consultant, spent a lot more time on the wards, visiting the wards. And the vast majority of inpatients, as Catherine said, had psoriasis. And I think the average length of stay used to be the order of 3 or 4 weeks, and it was just a
And
question
some
of,
often very much
yeah,
longer than
yes,
that.
painting them with coal tar,
Coal tar.
stuff you make the roads out of, and then doing that repeatedly. And the length, they would go home, and then often they would come back again. And nowadays, we have virtually no inpatients with psoriasis, and that's because of all the advances I'm sure we're going to talk about now. But it is incredible what the change was. Some of your older viewers may remember a famous TV show, which I think was in the 80s, called Singing Detective, which is a Dennis Potter play starring Michael Gambon as someone who suffered with psoriasis all over his body, and horrible psoriasis, who, when in hospital, would hallucinate that he was a private detective, and all strange things were happening to him. It's remade by Hollywood with Robert Downey Jr. playing the same character. And that's psoriasis. So that, you know, that sort of the life of someone with psoriasis in hospital was very well depicted in that show, and we don't see it anymore. It's
No.
I think
completely
the
changed.
other thing is also that a lot of patients with more severe disease were very unstable. So that sort of patients with bad psoriasis would then get sick as well from their skin because it was so uncontrolled. And I think that's also changed the sort of what we call erythrodermic psoriasis, where all of the skin is bright red and people feel unwell and shivery, and we had patients on ITU. I mean, there was it was also a much more unstable condition, I think. I mean, do you think that's true?
I
Do you
completely
agree?
agree. Yeah, young people who are really very, very sick,
Yeah, so
Very
it's-
unwell.
very unwell.
And just to wind back a bit, because we've been talking about psoriasis and scales, but maybe we could just go through what psoriasis typically looks like for, you know, the average person with psoriasis, and then maybe what it looks like for those inpatients or the patients with more severe psoriasis. Maybe Catherine, you could go into what you
typically
see.
it's red, scaly. People talk about salmon pink, scaly plaques or patches, typically on the knees and elbows, other sites of scalp, bottom of the back, and it can be localized to those areas or more generalized, and so the extent of the body surface. And that's what we call plaque psoriasis, and that's the commonest form of psoriasis. 90% of people with psoriasis, and of course there are much rarer forms of so-called pustular psoriasis, and so there's generalized pustular psoriasis and then pustular psoriasis on the hands and feet. But the common type of psoriasis that we're talking about, plaque psoriasis, that's typically what. And then of course it can involve the nails, it can involve the joints. So there's some psoriasis in the joints, and then there's a whole host of other comorbid conditions that are more common in people with more severe disease. So more severe disease is, I mean, that's something we should talk about, how you describe
definitely.
it, because it depends, and it's sort of moved on. But historically, more severe disease is purely on the extent of the disease. So the more extensive, then that's more severe. But of course, you can have really very active inflammatory disease at high need sites, we call high impact sites. So localized disease, but then it's still severe and has a big impact. And that's the other thing I think, Jonathan, that's really changed, is that the recognition and acknowledgement of the impact of psoriasis. Because when I started in training, the idea of asking how it was affecting a person's life, it just wasn't in the conversation. It really wasn't. And then there was this Andrew Finlay, this professor of dermatology in Cardiff, brought in the so-called Dermatology Life Quality Index, and that was really incredibly advanced idea that you might ask people, you know, how is it affecting the way you were living, your relationships, what did it mean, all the treatment and so on. So you can think about the disease severity in terms of what it looks like and where it is, and then disease severity in terms of the impact on the person.
And would you say that modern dermatological care, modern psoriasis care, is looking at a composite of all of those
I
things.
hope so. I do think
Yeah.
we are much more holistic in the
Yeah.
way we
Yeah.
describe and categorize.
And also how I think also we're more holistic in how we think about risks and causes of
Definitely,
disease as
yeah.
well. And I think that's under-recognized because
Yeah.
we talk about it all the time. And then sometimes in clinic, I had a patient like this yesterday. They're surprised when I talk about modifiable lifestyle factors. But we do care about those things, even as Western medicine doctors. And there's actually so much research to support that, which I know is a big aspect of your work.
Definitely. I don't know how well that's got out into primary care or people who aren't specialising in dermatology. I don't know
think
what you think.
some of the we'll probably come back to this, but some of the guidelines we have about when we can use certain medicines is kind of based on the severity scoring system of the body surface area, really.
Yeah.
It doesn't take enough account of where the psoriasis is. And where the psoriasis is very important because it has a huge effect on the person's life quality. So, if you've got psoriasis in exposed sites on your hands, on your feet, or on your face, for example, we've got psoriasis in the genital area. This is, it can be very localized, but it can have a horrible effect on your quality of life and the way you feel about yourself. And as Catherine says, I think we as clinicians, who certainly those of us who know about psoriasis, we do take a notice of that very much. For others, it's a little bit more challenging because the guidelines talks about numbers, doesn't take into account where the psoriasis is. So, but gradually things are evolving and getting better.
I think I challenge you there, actually, Jonathan. Certainly in the UK, the national guidelines do talk about high impact sites. I think what's in the UK, what's not taken into account is paying for the high cost drugs.
That's what I'm referring to.
So
yes,
high cost
it's the health
drugs,
resource, yes,
which we'll talk about later.
Yes.
That are these highly effective drugs are reserved for those patients using these inadequate tools that don't properly capture. So I think that's where the gap is. I think the guidelines are. The
guideline from the professionals is that's very clear.
Yeah.
But it's the economics really.
I think that it's the economics. Yeah. It's the economics of it. Yeah. So which by the way are the actual health economic analyses need better finessing, I think.
Yeah.
And the people who do those health economic analyses agree with that as well. It's they're informed by inadequate data actually to properly capture the benefit of the higher cost drugs. Anyway, that's probably a bit off topic.
That's okay. We'll come to focus on that a little bit more later on when we just talk about sort of the barriers to kind of implementing change in psoriasis care. Can I drag you back to giving us just a bit of an overview of what the key breakthroughs have been in your career in terms of, driving these sort of rapid changes that we've seen in improving psoriasis
Sorry,
care?
the things that happened during my time that's made psoriasis so much easier to deal with. Is that what you mean?
Exactly.
Like what was your understanding of psoriasis at the start, and how?
Well, if you look, if you look at old textbooks of psoriasis, psoriasis used to be in a section of the books called the disorders of keratinization. So it was thought to be a disease of something going wrong with the outer layer of skin. And that persisted really until the end of the 80s into the 90s. And then I think the first big change in how we look at psoriasis from a pathophysiology point of view and a treatment point of view was complete serendipity. And that involved a medicine called cyclosporin, which was being used to treat rheumatoid arthritis in a clinical trial. And rules about entry into clinical trials weren't quite as strict as they are now. And somehow some patients with psoriatic arthritis got included in the clinical trial. And the observers, rheumatologists, noted how rapidly the patients with psoriatic arthritis, the skin disease went away. And that complete serendipity, chance, and that led to science of the immunology of psoriasis suddenly exploding. And so throughout the 90s, psoriasis was increasingly been seen as an immunological disease. The T lymphocytes were central to the pathophysiology. Exactly what was going on, no one really knew, but people were looking in a different direction. I remember back, I think, Catherine, you mentioned methotrexate. The reason why we use methotrexate, which in essence, until cyclosporin was the only drug that we had to treat bad psoriasis, that was used in psoriasis because it stopped the epidermis from growing. It's a cancer drug. If you gave it at cancer doses, people's hair fell out. The hair follicle is an epidermal structure, and on the basis of that, some very brave souls in America tried it in psoriasis, admittedly at different doses. We now know that methotrexate works for a different reason, but that's the reason that methotrexate was tried. And then the second big thing that happened was again a bit of serendipity. And this is the dawn of the age of biologics for immunological disease. And I'm sure we'll come back to that. But a patient in America with Crohn's disease was given a biologic. The biologic was infliximab, for what it's worth. And that we know that there is an increased there's a slight association between Crohn's disease and psoriasis. One of the patients had psoriasis, and they observed the psoriasis melted away much more rapidly than the Crohn's disease. And so that led into the biologic revolution with the TNF inhibitors. So those were the two big pivotal things. And so we're talking really that life for patients with psoriasis started to really change for the better at the millennium, because that was when that was being reported. So yes, and then the things have moved on from there.
Yeah, and your work focused a bit on the genetics of psoriasis as well. Is that right?
Yes. So we there were sort of three big groups in the world working on the genetics of psoriasis, in the US, in Germany, and ourselves. This all came about because of the Human Genome Mapping Project, and when the human genome was sequenced for the first time, that produced technologies that allowed you to look at common diseases, because don't forget, psoriasis affects about 2% of the population. It's a common disease. It's not a rare so-called monogenic disease like other skin diseases, epidermolysis bullosa, for example, where there's an obvious genetic cause. So in collaboration with geneticists, when Catherine was involved in this, we collected patients, and we collected thousands of them. And actually nowadays we've collected tens of thousands of patients, and taken their DNA, usually from blood samples, and then the geneticists did their magic. And the incredible thing about the genetic experiments of psoriasis is that I don't know if you're interested, but it's called genome-wide association scan. What was incredible about the genome-wide association scans in psoriasis was that it matched up perfectly with what the immunologists were doing at the same time. And so you moved from wondering about whether immunological mechanisms were primary or secondary to suddenly knowing that these were the primary
drivers.
the primary pathways involved in the disease. And that was going on around about the millennium. Yes, in the early noughties, that was going on.
There's almost like a coalescence of
That's right.
events,
Yes,
I guess.
yes.
So technological advancements in
That's right.
sequencing.
That's right.
And a greater understanding of the immunopathogenesis from these serendipitous trials, essentially, in other conditions. To me, that suggests that maybe we shouldn't be. We should think a bit more laterally about how we're doing our clinical trials. Otherwise, we're missing in some of these discoveries, aren't we?
Well, that's right, and this goes back to what you were saying right at the beginning about moving towards precision medicine. I mean, that's exactly what we should be doing.
But it also shows the importance of just keeping your eyes open.
Yeah.
Yeah.
all the time. So
Yeah.
the kind of clinical observation,
Yeah.
watching
Yeah.
can
Yeah.
can tell
Yeah.
you something.
Yeah.
Yeah.
I mean, I would say it, wouldn't I? But the thing about immunology is you can measure everything going up and down.
Mm.
Just about everything changes, and trying to find the needle in the haystack requires something outside.
Yeah.
And in the case of psoriasis, I think it was the genetics.
Yeah.
So there you go.
Yeah.
Well,
my-
it tells you what's causal,
Yes.
doesn't it? It
Yes.
tells you what's causal
Yeah.
rather than
Yeah.
Yeah.
You mean the genetics?
Yes,
Yes.
yes.
That's the primary
It's
causal biology.
Yeah.
It
Yeah.
tells you the causal biology.
So if a psoriasis patient was here and they asked you, why have I got this? You would
Yes.
say it's because of your immune system.
If patients do ask us that.
Yes.
And
And what's your answer?
my answer to that is I say for two reasons. One reason is you inherited the risk of developing the disease, and
Yeah.
that's the genetics. And secondly, something in the environment, something has worked with the genetics to make that risk a reality.
Mhm.
Most of the time, we haven't got a clue what it is,
Yeah.
but sometimes we do, and we'll talk about this, I'm sure. But lifestyle are a very important thing.
Yes.
And I said the genetics has also told us
Yeah.
that this is an immunological phenomenon.
Mm.
Doesn't mean to say, I'm talking to you as the patient.
Yeah. Yeah.
It doesn't mean to say your immunology system is wrong.
Yeah.
It's just that there's one bit of it is being tickled up in the skin for some reason.
Yeah.
And you've ended up with this condition.
I mean, I think what sometimes it's quite helpful to say is the immune system is actually super clever, and it's actually in overdrive. If you've got psoriasis, you're actually better protected against, for example, viral infections. So I think sometimes it's quite helpful for people to know that, because they feel that their immune system is defective or weak. It's quite the reverse, actually.
Yeah.
So
It's a bit too strong.
yeah. And I think the point about the environment is very important to make, because there's so much that we don't understand about
People have
the environment.
bright people have speculated about this phenomenon, about making sure you've got a good skin immune system in evolutionary terms.
Yeah.
So because we are hairless animals,
Mm-hmm.
we are the only animals that get psoriasis. It's different from atopic dermatitis, where many other animals get it. Only humans get psoriasis, and some people think it's the price that 2% of us pay to have an adequate skin immune system that allows us to be hairless, this, that, and the other. It needs to be worked through, and we need to understand that. But that has been speculated, which I think is quite interesting.
Yeah. It's an interesting concept.
We've mentioned a little bit about the environmental factors or triggers of psoriasis. Can you talk us through what some of the key sort of modifiable risk factors are?
Well, I guess, modifiable, or maybe to start with what the environmental factors are. So one of the big ones is streptococcal infection, or infection as a trigger to psoriasis. The archetypal being strep then triggers off this so-called guttate psoriasis, which is a typical pattern, and then can become a recurrent driver. So in a way, you mentioned the word modifiable, but if you come into contact with a streptococcal infection, that's not modifiable,
No.
is it? And there's going to be a whole host, I'm sure, of other as yet unidentified environmental triggers that we just don't know anything about. Similarly, there are certain drugs that trigger off psoriasis in genetically susceptible individuals. The typical one is beta blockers, very commonly used for high blood pressure. Lithium is another one. And again, there are probably other drug factors.
Antimalarials.
Yes. What are the other ones?
I think they're the big ones. They used to say the old drugs used in for rheumatoid arthritis, like Gol and penicillamine,
That's right,
are also
but they're not really
implicated.
used anymore.
But they're not.
That's right.
Yeah.
That's right.
I mean, I think it's unusual to get a history of drugs being related to the onset of psoriasis.
That's right.
It's written about in the textbooks, but it's not a common phenomenon.
I mean, and we should also perhaps make the distinction between what triggers it for the first time and then what drives it to go on. And I mean, the other big trigger is stress in its broadest sense. So that comes out from real world data, but it's also from self-report surveys. Even quite recently, in fact, we did this big survey, and stressful events were by far the most common cited trigger for both triggering of psoriasis and then exacerbating psoriasis. So major life events, as well as ongoing, living in.
And do we have any understanding of the mechanism behind that? Or like, how
Not
does
really,
stress
no. I mean,
trigger
it's very,
psoriasis?
very.
Because is that not mechanistically
Yeah, I mean,
quite
yeah,
important?
it is. I
Is
agree,
it is it doing something to the immune system and
Well,
therefore influencing
presumably,
it, or is
presumably
there
it
a
must be,
direct?
or whether it's a gene.
Yeah.
I don't know, a gene environmental. I really don't. I don't know. I don't know whether you know anything more, but I think
No.
the problem with that area of research is how do you characterize stress? How do you measure it? How do you get it in some sort of reproducible way? How do you actually go about investigating
Well,
that?
the reason I ask is because people are obsessed with cortisol. Like constantly, people ask about, I don't want to spike my cortisol, and is cortisol causing it? But I'm guessing that's probably not been investigated in a proper way in psoriasis.
I don't think I'm not aware of any very high quality modern research in this area, but
it's a challenging thing because it's inconsistent as well. I mean, so it would be a very difficult thing to investigate. But I completely agree with Catherine that it's an important it's important in terms of flaring of disease.
Yeah,
and I think you're right. Also, understanding the mechanism could open up avenues for different therapeutic strategies. I mean, I do know also that people with psoriasis can get understandably annoyed and irritated by members of sometimes the lay public. So it's all stress, just calm down and you'll be fine. I mean, that's
most
not what we're
infuriating
talking
thing.
about. It's
No.
absolutely infuriating.
Yeah.
But so I think that's a very common thing. And then the other things, then you mentioned modifiable, and maybe they're not so easy to modify anyway, but certainly smoking can be a trigger to psoriasis, in particular pustular forms of psoriasis on the hands and feet. That's very, very strongly associated and causally, that we've got good genetic studies showing that there's a causal relationship between smoking and pustular forms of psoriasis. Alcohol is another factor, excessive alcohol. But the relationship between psoriasis, I don't know what you think about it, but I think the relationship between psoriasis and alcohol is tricky to unpick. Would you agree?
I completely agree.
Yeah.
But all of these things, they're so interwoven, is trying to unpick them all is very challenging.
And then the other factor that we do know about is excess body weight, carrying extra weight, and we know that is definitely a causal trigger for psoriasis. So there was a study we did a few years ago from Norway, using the Norway electronic health data, and we estimated around a third of psoriasis was avoidable if the population all had a healthy body weight. So it's definitely a trigger, and it can also drive disease severity. And we've done a recent study suggesting it also depends on where the fat is in terms of its relationship with psoriasis. So, and it's around your middle. It's that fat around your middle that you want to try and avoid. But of course, that's common in lots of inflammatory skin disease. It's not unique to psoriasis.
No, it's not unique. And it's interesting because also, you've done work in cardiovascular comorbidity and psoriasis, and we associate that abdominal adipose tissue with cardiovascular risk as well. So there is like a thread linking all of these things together, aren't there?
Yeah. But I think, it's tricky.
Yeah,
it's tricky.
Very
It's
tricky.
It's very tricky.
And a question again that I got asked in clinic yesterday was about diet, because and it happens often in clinic. Patients will ask you, what should I eat to try and get this better? Because whenever I see a patient with any inflammatory skin disease, I talk about things that we can do for them and things that they can do for themselves. And diet is something that people often look to try and modify for themselves. And there tends to be a message on social media, and probably from well-meaning family and friends, about excluding this or excluding that. So dairy, gluten are often like the two. I'd say those are the two most common things that people try excluding. Do you think there's any evidence for a specific exclusion, or do you ever make a specific dietary recommendation for your patients?
Well, I think my general advice is eat healthily. So I say follow the advice that you would for the general population, for people without psoriasis. So as far as I'm aware, there's no really strong evidence for excluding anything in particular. I mean, the research is poor. I think the quality of the research is not good. It's, again, a very difficult area to tackle. And actually, now that we've got better traction on the basic genetics and the biology, and we've got better drugs, maybe now is the time to try and unpick the diet bit. But I think there is this, I mean, Jonathan, you might want to say about the relationship between celiac disease and psoriasis, because there's a bit of a crossover, isn't there, genetically between the two?
A very, very slight one, yes.
And
I mean,
certainly there is a,
but
there
it's
are a
never
few
been.
studies suggesting there are some patients. Do you agree with this? You might not agree with this.
I don't.
You don't.
I mean, I do agree that there are some studies. I don't agree that they're very good, or it's very weak evidence.
So what do you say to your patients then about gluten?
I say there's no good evidence linking it.
But if a patient wanted to try going on a gluten-free
If
diet,
patients want to try it,
would you test them for celiac disease?
no,
I quite often do that.
no, and the answer is
Well, occasionally you do get, but then of course there's prevalent celiac disease.
Exactly.
So
exactly right.
I think, but to go back to the observation of, observations of individual few patients, there are some very compelling, the odd case. So I think.
Well, of excluding gluten.
Yeah, but which patients, which subset? I think it's minority.
I think generalizing is very challenging.
Yeah,
I think that's right.
I agree.
There will always be strange events that we cannot explain, and we just need to do more work to try and explain it. But as general advice, it's probably not going to help the vast majority of people with psoriasis. Sadly, I wish it would, because
I agree with that.
because so many people ask the question, and if you could, by a simple modification, make the psoriasis go away, fantastic. But I'm afraid that's just not going to happen.
No.
Can I just go back to your points? I think you, Beibei, about and Catherine's point about excess weight. And what's clear is that if you have excess weight, you, as we all know, you are at risk of a number of other medical conditions coming along, whether it's cardiovascular disease or whatever. And I don't think there's any need in the psoriasis for people who have psoriasis to give them different advice. But I think that if you do have excess weight and you do have psoriasis, it makes a lot of sense to think about managing it, because not only have you got the general lifestyle issues, cardiovascular disease, type 2 diabetes to worry about, but there is evidence, and Catherine, please correct me if I'm wrong here, that the medicines that we need to give you for your psoriasis will likely work better if you don't weigh so much. And also there is some evidence that weight loss can actually help your psoriasis. There's two reasons why you might want to think about it. I won't say much more, but it is important. So in the clinic, thinking of all of these things about the diet, lifestyle is an important part of the management these days, I think, of psoriasis. Would you agree with that, Catherine?
I completely agree with you. But I also think that, I feel that we could do much better at supporting people. Because I think that, and also we did a bit of, I had a really very good psychology PhD student a few years ago, and she did some very interesting interviews with people with psoriasis and who were carrying extra weight, and there's no one who doesn't know that they're carrying extra weight. You're not telling them, you're not informing them about anything but having bad psoriasis, often people's moods very low, they need support to get the psoriasis better. Many patients said, if my psoriasis is better, I would be in a better way of being able to do something about my weight. And so I think as dermatologists, we have to focus on really using treatments well,
Mm.
helping to clear the psoriasis, because the evidence also is then that people do then feel better and can it's actually, you're in a good place then to try and address your other health aspects and lifestyle, the rest of it. So I think what's not helpful is, well, you know, you need to go and lose some weight. How can I help you? Because, you know, you're not helping yourself. So I think it's a conversation that we need to be much better at, I think.
Yeah.
Actually.
Yeah.
Do you agree?
Totally.
definitely.
Totally. I think that we are under-resourced in that area, both in our training and also in what we're able to deliver as a health service.
Yeah.
Because we can't implement change by, you know, obviously our clinical consultation is important, but one small piece of education is only going to have a finite amount of impact. And I think that in order to enact behavioural change, you need multiple points of contact over that patient's journey. And you're kind of rewiring habits, aren't you? And they may be built in from childhood. It's a very difficult thing to address. And you have to look at the bigger picture of what they're doing with their time throughout their day. Maybe they're working 10-hour shifts.
Well, that's the other thing, you know, the environment is just obesogenic, isn't it?
Yeah.
But that's where these new drugs, though, I think, are really very, very exciting.
Because it unlocks one barrier to achieving better health in general. And, you know, in terms of the risks associating psoriasis and cardiovascular disease, do you think that, you know, someone who has psoriasis should be, you know, thinking about their cardiovascular risk more than the average person?
Well, what we know is that most people with psoriasis aren't at increased risk of cardiovascular disease. So any risk, an association, is only those patients with more severe disease. That's well evident. So if you've got mild psoriasis, you know,
it's fine.
Yeah. The second thing is the relationship between cardiovascular disease and psoriasis. It's not, well, there's certainly some evidence that suggests it's not necessarily the psoriasis that's driving the risk. May actually be the other way around. And maybe patients got cardiovascular disease and the psoriasis is a flag for it. So that's the recent study that we published that suggested the causal biology was actually not quite in the way that it's being promoted. So, and I think that for the general population, and that would include people with psoriasis, then yes, look at cardio. So if you've got more severe disease, we should be managing cardiovascular risk properly and holistically. So in the psoriasis clinic, in our psoriasis clinic, we routinely measure weight, blood pressure, talk about other cardiovascular risk,
lipids.
I think what Catherine said is very important. Particularly the bit about the vast majority of people with psoriasis are not at increased risk of cardiovascular disease because they've got psoriasis. And unfortunately, there is a lot out there written that's kind of made an association, and that people have been led to believe by some of this that there is an association, and it only applies in very specific situations. And when we talk about our psoriasis clinic, we are talking about the patients with very severe psoriasis, generally speaking. We're not talking about the vast majority of people who have very localized psoriasis. And so I think that's a very important message.
So let's talk a bit about how all of these advances in our understanding ultimately led to a completely new treatment pathway for patients with psoriasis. So at the beginning, we were talking about our 60 patients with psoriasis having coal tar painted on their knees and elbows, presumably, as an inpatient for between 4 to 7 weeks. Now they come to our general clinic or the psoriasis clinic and they get given sometimes creams for localized disease, but often tablets and injections. So let's talk a bit about the injections, because that's really what's transformed psoriasis care.
Can I go first on this?
Yes,
just because Catherine knows much more about patient pathways than I do. But I can just finish my little story that I started
Yeah.
again. So we broke off when there was this serendipitous observation that a patient with a bowel disease, inflammatory bowel disease, who also had psoriasis, their psoriasis got better, and the drug they were given was called infliximab, and infliximab inhibits a chemical in the blood called tumor necrosis factor, TNF. And as a result of that, suddenly there was development of medicines that inhibited TNF by injection, biologics, for patients with plaque psoriasis. And they worked incredibly well. And at that point, we did, for example, we did an audit, or it was Catherine's audit, of inpatient episodes. And when those medicines came in, we noted an 80% drop in inpatient episodes for psoriasis. So the advent of TNF inhibitors for psoriasis was a huge step forward.
And what year was that in?
And that was round about 2005, 2006. That's when NICE approved etanercept for the treatment of psoriasis. And then then a little bit later, adalimumab came along. While that was going on, that's when that was around the time that the genetics was going on, and understanding the immunology of psoriasis. And the outcome of that research from the immunology and the genetics was that there were two other chemicals that seemed to be crucial, in interconnected chemicals that called cytokines that were crucial in the pathophysiology of psoriasis. One was called interleukin-17, and the other is called interleukin-23, and they are interconnected. But the genetics said it was causal, the immunology proved it was important, and consequently, drugs were developed that inhibited IL-17 and IL-23. And those medicines have been incredibly effective in the treatment of psoriasis. A little bit better probably than the TNF inhibitors, generally speaking, and requiring less dosing usually as well. So now we've got biologics for TNF, we've got biologics for interleukin-17, we've got biologics for interleukin-23. And when you select your patient correctly, which I guess we'll talk about in a minute, the outcome is incredible. And at this moment in time, if we have an inpatient, it's because they've with psoriasis, that is, it's because they're new to our service and haven't had access to these treatments before, or they've got a strange form of psoriasis, like pustular forms of psoriasis, which we now know is mechanistically completely different, and they don't respond so well. We only rarely see patients with plaque psoriasis in the hospital now. It's an unbelievable change. So on the basis of that, the question then is who gets access to these medicines, which I think is what your question is. And Catherine, over to you, really.
Well, and just to make the distinction between the TNF story, which was serendipity, the subsequent classes were really designer drugs. They were designed to target the pathways that were absolutely
and not borrowed from other diseases. They were developed for psoriasis.
And the other, I mean, also we need industry to develop these drugs. So it was also just to make the point that psoriasis wasn't on the map, wasn't on the pharmaceutical map before the biologics. No one was interested in designing drugs. I mean, it's incredible to think about it now because it's such a crowded pharmaceutical space, but it was incredibly important for skin disease in general. It was really one of the first skin diseases that drew attention to the fact that there was this massive unmet need of people with skin problems, and that there was biology that was tractable with drugs. So it's been a ride.
It's changed dermatology.
I think it really has. I mean, it really has. I mean, these drugs have changed inflammatory diseases across joints, skin, and the gut.
But I guess it changed dermatology in the sense that it put dermatology on the map as well, hasn't it?
No, absolutely it did.
Yeah,
absolutely right.
We've spoken quite a lot about sort of systemic treatments, but what about the topical treatments? Why do you think there's not been such an interest in sort of making novel topical treatments for psoriasis?
Why isn't there a topical IL-17?
Well, the sad truth is there hasn't been a new effective chemical entity for the topical treatment of psoriasis since 1992, when calcipotriol came along. There's been nothing really new there. There have been two new medicines recently come out of America. They're not available in the rest of the world. They're extremely expensive, and it's very doubtful whether we're going to see them anytime soon. I'm sorry, you asked something else about what.
Why is there no topical IL-17?
I don't know the answer. At the moment, all IL-17 inhibitors are biologics, which are
Yeah.
big molecules, and
I see.
you can't make
So it's a
creams
delivery.
out of because of delivery.
I see.
The possibly one hope is that there is a new class of immune modulating drug, which is called JAK, isn't it? And there are JAK
JAK
inhibitors, and these are new drugs that are used in other areas of dermatology, like atopic dermatitis, for example, and also in rheumatology. Those medicines, the so-called JAK inhibitors, are small molecules given orally. And there have been some developments of topical JAK inhibitors for eczema, and I think a bit of work in psoriasis, so we need to watch that space. But there is something happening. But it's not an area, I think, that appeals very much to the pharmaceutical industry, unfortunately.
Yeah.
Is topical drugs for psoriasis.
But you could also argue that anyway, if you've got at least moderate disease, however you might describe it, you know, putting creams and ointments over any substantial proportion of your body on a daily basis, unless it's something that works brilliantly and then you can stop it, it's quite a burden. So you know, the systemic approach to management for anything more than but very localized disease, I think, is really we need to bring.
Yeah.
We need to try and improve access for more moderate patients, I think.
Yeah, so Catherine, you know, Ali asked earlier on about patients in the general clinic, and you know, well, from primary care into
I was going to say,
into secondary
maybe
care.
the practice at St John's is a bit different to everyone.
Yeah.
I mean, the normal pathway of care, certainly in the UK anyway, and and I don't know, but basically, a patient will present their first contact with a healthcare professional. Let's put it like that. They'll be offered creams and ointments. And then if they've got more significant disease, however you might describe it, then and either body surface area or high impact sites or arthritis or involving nails, for example, you then need to go on and use a systemic therapy or, of course, phototherapy, light treatment. So that is the pathway of care. But I mean, in the UK, it's mainly dealt with by primary care physicians and with creams and ointments, really. So there's a bit of a problem, first of all, in escalating referral of the right population to specialist care, because specialist care is the only place that you can get the injections, the tablets, the phototherapy. So those are, you have to go to see a dermatologist, and I mean that's true in most parts of the world as well. But you need to see specialists. What was your question, Jonathan? And why isn't everybody using?
Yes, and how can we improve access? And you know, if we've said a lot about these new medicines, can we increase access to these medicines?
Well, I think
And is it just a question of the makeup of how we organize our clinics? Is it just an economic thing? What is it? What is it?
Well, I think it's multiple. I think the evidence suggests it's multiple factors. Firstly, starting with the individual concern with psoriasis and people understanding and knowing. This is why I'm quite keen to do this podcast, to be honest. People need to know that there are these amazing treatments, that psoriasis is very treatable. And there are a lot of people. And so we know when we looked in the UK data for the first time during COVID to see what proportion of people who were actually on a biologic, only about 10% of the population who would even qualify, even under what might be said is quite a high bar for a biologic. There's only a minority of people who are actually getting it, and that's partly because they're not being referred. Maybe they don't know. Maybe they've had a first contact with their GP or whoever, and it wasn't a good interaction. Lots and lots of reasons. So that's the first thing, making people feel
Aware.
positive and aware that there are treatments. The second thing is education, I think, in primary care, because again, even now we did a seminar with primary care clinicians in this patch. A lot of them didn't really know about biologics for psoriasis, honestly. Even now, they've been around for 15 years. So, and I think being a GP is really hard. It's really, really hard. If you think of the escalation in therapeutics for just our single patch, and that's being replicated right across medicine, how in primary care can you possibly? I think there's something there.
Yeah.
And then the third big bit, obviously, is the bar for biologics and targeted therapies. They're called high cost drugs because they are high cost. Means that then the health economics mean that you've got to have a certain level of disease severity.
So how much is a biologic to the NHS? What does it cost to the NHS?
Well, the drug acquisition costs are for in general, and there is variation. That is a very general thing, and it's between £10,000 to £15,000 a year on year. The biosimilars, of course. Now, some of the drugs that, for example, lots of the TNF drugs now, most of the TNF drugs are off patent. So the cost now is hundreds of pounds now. So it's a fraction of the cost. But of course, well, certainly in the NHS anyway, that money saving is going to be used to fund other high cost drugs because, of course, medicine in general, there are huge advances in all regions so the drug acquisition costs across the whole of healthcare. So I don't think.
Catherine, can I ask Catherine?
Jonathan gets very upset about this.
No, the
So do I, actually. I mean, so do I. But I think you have to realise the NHS has got a finite pot.
You chaired a committee that produced a very influential clinical guidance paper on psoriasis for NICE, which was incredibly helpful for all of us, and is widely followed by our colleagues around in the UK. And of course, often the approach in that, I think that was back in 2017. Would that be correct?
2012 was the
Sorry, 2012.
CG153.
Yeah, that's it. CG153. Of course, things have changed so much since then, particularly the advent of the biosimilars. And when Catherine was just quoting you a price for the biologics, the biosimilars are much less than that. And so, generally speaking, we will start with the biosimilars for economic reasons, and we have some very good biosimilars now. They're extremely good. But we need the guide. What I'm asking, I guess, is there likely to be any update on that guidance, given the fact that there are now some biosimilars out there that change the economic model quite a lot?
Well, in fact, I'm just about to start on an update of the NICE CG153 in actual fact, but and so that will certainly be mentioned. We're going to discuss what the scope of it is, and that won't be just down to me. Obviously, it's down to the whole grit and the. But I think my point I was saying earlier, the health economics of analyses that were done when the drugs cost £10,000 to £15,000 a year. Obviously, the analysis will be different when the drug acquisition costs are much lower.
Yeah.
I mean, I think the other thing about the health economic analyses is that they're projected on a lifetime of use, and so maybe we'll come into that. But maybe, and there is increasing evidence that, at least there's it's not strong evidence, but there's encouraging signs that maybe if you get in earlier and get people into remission and clearance, there's opportunity to stop the drug. And so
Mm.
that will then, of course, change the whole economics of it, because obviously, if you're not using the drug long term, then, I mean, apart from being brilliant for people with psoriasis that they're not having to take a drug long term, there's obviously not a long term drug cost. So that our whole pathways to a biologic, or these what we call high cost drugs, is predicated on the idea of needing it long term, and therefore you delay getting onto it because you want to keep the biggest population on the lowest cost drug. But maybe we need to think about it, in a completely different way. I mean, we do anyway, because I think clinicians have and people with psoriasis patients have an idea that these systemic drugs are, dangerous or strong or whatever, but actually it's clouded with the mindset of the legacy of the old-fashioned drugs like cyclosporin and methotrexate, which either didn't make you feel great or they did cause cyclosporin caused long-term kidney damage. But we know that these targeted biologics in the main are incredibly safe because we've got really good data now. And so there's also something about being confident about using these very effective drugs earlier with less monitoring. Less monitoring, less blood tests and so on.
So do you think we're on the precipice of another shift in how we're using these high cost drugs, because we're moving from them being high cost to actually maybe comparable to our traditional medications? And obviously with the safety profile and the reduced need for monitoring, there is an impact.
These are high value drugs now.
Yeah,
we should
they are
talk
high
about
value.
high value drugs rather than high cost drugs.
Yeah.
They're high value drugs. So I do really feel, and I think then that's why I'm very excited about the idea also, if we can get some handle on the population who're going to go on to have more severe disease with our biomarkers or genetics or whatever, and identify that that higher need population earlier.
Yeah.
Then there's opportunities to come in
and intervene.
Yes. The premise that everyone with patch of psoriasis should get a biologic is over medicalizing the problem massively. I think we need to have better stratification. But it's encouraging. There's lots of stuff going on. It's really exciting, I think.
One of the things that you're looking at the moment is how often we need to dose the drug, how often we need to give it, and you're looking at the pharmacokinetics of the drug. And I think that's something that will also change how we sort of the pathway of what we give and the costing of it as well. Can you tell us a little bit more about that work? And
well, the biologics, like most drugs, when you develop a drug, you decide the dose based on the dose that fits most of the population. So it's based on population profiling, because the biologic drugs are safe, the pharmaceutical development has allowed the dose to be pushed high. You obviously can't do that with much smaller molecules. You have to be much more careful. But with the biologics, you can push the dose high, and therefore, in order to capture more of the population. So we know within the population, there are certainly a lot of patients, at least some patients, who are I've got more drug on board than they need. And so, and maybe some patients need a bit more drug. So the work we've been done has been measuring how much drug is right, and to try and individualize the dosing of the drug, with the idea that some patients, especially once they're in remission, could do with much less drug. So colleague Satva Mahil is doing a big trial on this in people who are clear on their biologic. Can they then have an individualized dosing strategy? And she was saying the other day, some patients, the standard dosing is every 3 months, and some patients haven't needed another dose for 9 months. So that's also
a huge impact
on the road to getting much more individualized therapy. And obviously less drug is less money.
So I mean, it's a double winner. It's less money, and it's tailored to the patient. And it's also true that if we could in some way develop algorithms that allowed us to predict who those people might be, the type of psoriasis they've got, issues around, I don't know, weight, um, and then issues around doing blood tests to understand the immunological bent of their psoriasis. Is it over here immunologically, or is it over there? So some form of what's sometimes described as molecular phenotyping the patient, whether it's their blood or their skin. So to put all of this together in a big picture, to try and help predict the best dosing from the beginning of the right drug, isn't it?
Yeah, that's the
Is
other
that-
thing
is-
of the right drug.
Yeah.
Yeah.
Yeah, I mean, I think psoriasis is I think we're in a situation now. Don't tell me if you agree or not. With there is this sort of mantra in the health service of get it right first time. I think psoriasis has suffered big time from not getting it right first time. You know, I hate to misquote the Psoriasis Association, but I think they talk about sort of the average wait for a patient to get decent care with psoriasis is something like 9 years.
Wow.
It's
Yeah, it's a long
terrible.
time.
But if we could somehow shorten that interval, so as Catherine was saying, treat better earlier, um, try and minimize life morbidity, but trying to do that in a scientific way,
Yeah.
using various clinical and lab-based parameters, maybe imaging or whatever. I think would be fabulous, and I think we're just about there. You know, we're just about to start that little bit. I don't see amazing new drugs coming for psoriasis in the short term,
No.
because to be honest with you, we've already got them.
They're all there.
Yeah,
We don't need them really. I mean,
yeah,
there
it's
are
a question
different.
of
There are
refining
oral,
it and
I think
this, that.
there are
Yes,
the sort of oral forms
yes.
of the biologics. So there are
It's
some
it's evolution
clever
now,
sort of
not revolution. Yeah.
bioengineering
Yeah.
of, because we have the biologics have to be given as an injection. I mean,
Mm.
it's not such a massive deal, but there are trials going on of
Yes.
these being
Yeah.
given by mouth. But yeah, I agree. But we don't really need them because we've got these. We've got very good drugs. I
So-
mean, it is true there is a subset of a subset of the subset with very severe disease who do have very, very difficult disease that doesn't seem to respond or they rapidly fail. And we need to understand that failure on treatment, and that, because I don't know, there may be people listening who say, oh, you know, I've got terrible disease, I've been through every treatment and nothing's working. And I think it is true.
Yes.
There's still unmet need for
Always.
important subsets of the population, but in the main, it's really, and it's also true for psoriatic arthritis. I mean, we haven't talked about it very much, but it's certainly true that these drugs also work in arthritis.
So it's now more about, you know, we know that these drugs work, they're highly effective. Now it's about refining how we deliver this drug to the right people, to everyone, to all the people who need it, and in the right doses and personalized to their individual phenotype of psoriasis.
Yeah.
So, which to be honest, that kind of level of precision medicine, it's not really, it's not really been successfully carried out in most areas, most specialties.
No.
So actually, dermatology could be pioneering in this area, I think, which is, and that's because the treatments we have are so good, and we have such good understanding of, you know, the molecular drivers of psoriasis. So,
Well, I mean, and also, I mean, Jonathan, HLA CO602, you know, that's a pretty good stratifier about. You've already got quite good genetic stratifiers for which class roughly of biologic that you want. And we've already got tractable clinical parameters as well that we know are important in terms of, and then we've got the PK. So we're going to put it all together. I mean, that's the
I think it
plan.
needs to
That
be
is
put
what
together.
we're putting
Yeah.
it all together to make it, because there is, having these ideas and moving research into the clinic is always a challenge, actually. And it's probably not been of sufficient focus. I mean, we did that scoping review a couple of years ago, and there are almost all the precision medicine markers, biomarkers, so millions of billions of dollars spent, but it's all sitting in the discovery phase. None of the work is through, very little of the work is through to the implementation, taking it all the way through. So I think we've got to.
what are the barriers to that implementation? Like, why is so much, because so much money is spent on research, and people are always looking for new biomarkers, but if you say they're actually all there in the literature, but just not followed through, what are the barriers to that, and what can we do to
It's an
improve
interesting
that?
question. I tell you, one of the things I realised that in COVID,
Yeah.
I really it came to in COVID is that during COVID, and it was a terrible, terrible time, but one of the really positive thing about it was that everyone in the research and clinical community was focused on that one problem, and the power of having everyone thinking and working in one direction, in one to one end, was extraordinarily powerful. It was really powerful because things got done at speed, and of course there were lots of other reasons, but that influenced how I thought about the research that we were doing, and that the importance of focusing, being very focused, and then trying to think it all the way through to your policy. What's your policy and what do you need between? And I think that because there are multiple gaps, so for example, the researchers who are doing the discovery science aren't necessarily talking and working with the clinicians on the ground. There aren't the data sets or accessing data sets to validate it, whatever they found. So there's one thing about, you discover something, can you replicate it? Does it work in the real world? And then training individuals to use it. Do they understand it? Who's going to do the diagnostic test? All of that stuff, all the way through. And then, can we afford it? Can we afford the test? Is the test worth doing? So, for example, measuring a drug level, actually, depending on the drug, but it costs about 60 quid a throw. Is it quicker just to carry on and see what happens and then stop it 3 months later? Do you see what I mean? So you've got to think of the whole pipeline. And so I think there are multiple barriers, and we need to all be deciding what the most important one or two questions are. So to me, I think collectively getting a handle on who are the higher need population, who are going to go on and develop more severe disease. I think that's a really important thing to try. I mean, do you agree? What do you think? I mean, what do you think?
Well, I agree with most of what you've said. I completely agree about identifying populations, because there's all kinds of preventative things we may be able to do, and treating early, etc. How we go about identifying the what are the biomarkers, for example, and you saying that we have got them. It's just a question of finding them. That's a challenging thing,
I don't
because
mean
I'm
well.
not
No,
sure that we necessarily do, and or that we're going about it in the right way. But look, I mean, this is all a bit
No, I don't
arguing,
know. I
because
don't know whether that golden biomarker is in that haystack of discovery science. I don't know whether it's already been found, but I do know that there's what is definitely true is that there's a lot of work done in the discovery phase. People do it on small cohorts. They've found this exciting thing, but taking it through to the next stage and making it, but maybe you're right. Maybe it's because it's not exciting enough.
this is becoming more philosophical.
Yeah.
But buried in there was an important thing. Is it would be very helpful if, for example, the pharmaceutical industry, when they're conducting studies and trials, could share all the data with the scientific community. I mean, there's so much in there that we never get to see, and it's a shame. It's a shame. There are, for example, little groups of people who have amazing responses. Just a whiff of a drug and their disease goes away. Others, nothing happens, and we know that there are samples there. It would be wonderful if we're in a position to do that. I realise there's all kinds of problems, data protection, all kinds of things. But it would be nice. I think that would be very helpful.
I do, yeah. Although I would say, I mean, as you know, we were involved in that European consortium, Biomap, and that was a really good industry academic partnership. And we worked over a period of 5 or 6 years. We worked out. I mean, I had much better understanding of what industry were able to share and what they couldn't share. But one thing we did do, which was really good, is that if the academic groups identified a biomarker, then in this consortium, then the industry partners were very happy to run in their own data sets, seeing could they replicate it. And that was brilliant because we had this whole stack of different biomarkers. And then within a few weeks, we knew, well, actually, no, that's not worth taking forward because it's not replicable in an independent data set. So the power of working in a way that does work between industry and academic is actually, it's a worthwhile endeavor. I was really convinced actually doing that consortium.
I guess consortium efforts, you're just bringing together more people.
Yeah.
There's more power in the
Yeah.
data that you have, and they're also independent data sets.
Yeah, they're independent data sets. Yeah.
So that's
and
very
as Jonathan
useful.
said,
Yeah.
there are lots of data sets which actually individually aren't much use anyway. So so that was we need to get more ongoing funding for it. But I'm more optimistic. Jonathan often says there's a difference.
There's a thin line between
optimism
optimism and
delusion.
delusion.
He said that to me for most of my professional life.
We've spoken a bit about early treatment, remission. And I think there's this fascinating concept of memory immunity in the skin. And, in the dermatology clinic of the future, we obviously are able to identify our potentially severe cohort, get them the right personal treatment dosed in the right way. Is it possible to get them into long-term remission, where you can treat them, periodically or just a few times, and then they are free of their psoriasis? They obviously don't change their genes, but they're free of that, that activation of their genes. Do you think that's possible?
Yeah. I think that we shouldn't use the word cure because apart from anything else, as you've quite rightly said, you aren't going to change their innate disease susceptibility, but you could put them into deep remission or a pre-disease state. Yes, I do actually. I do. And we know also from trials that there are certain patients who, when they're clear, and that's what we're researching now, that then you take them off the drug and their disease doesn't come back.
I mean, it is interesting that often's probably not the right word, but but if psoriasis does clear and stays clear, when it comes back, it does seem to come back in the same places it was before. And there've been immunology, and I think this is what you're referring to, Bev, that if you take biopsies of the skin, you can find in those areas of skin, when the psoriasis is cleared, that the memory cells, the resident memories, T cells, are still there. And so there is a lot of discussion about can you get rid of those? Can you sort of adapt dosing of drug, or maybe do it in different ways? But I think that is an attractive concept, and I completely agree. It's not to talk about cure, but I think there's a way of probably changing the way we deliver medicines to try and improve the length of time between relapses, if you like.
I mean, as a conceptual framework as well, it actually has been in psoriasis for decades, because if you think of phototherapy, people come in with a flare of their psoriasis, you give them phototherapy. We know some patients have an episode of phototherapy and they clear their psoriasis and they don't, it stays away for a long time. So I think it's definitely theoretically possible. And we know, I think there's that we need to understand what it is that confers the memory. Is it the TRM or the epigenetic changes, other cells, fibroblasts of the new cell that are also contributing to that? I mean, you know about this, Beibei. You know all about this. It's complex. It's probably complex, isn't it?
Yeah. And do we know what's special about psoriasis? Why does it come up on our elbows, on our sort of the lower back, the scalp? What is special about those sites, do you think, that makes psoriasis go to those places?
Well, there's two things about the distribution of psoriasis that are weird, I think. One is where it is, and the other is the fact that it's nearly always very symmetrical. And the fact that it's very symmetrical, that sort of refers back to this, when we were talking about stress, there is some neuroimmunological phenomenon we have no idea what it is, but that would tends to explain the symmetricality. Psoriasis, particularly its localized forms, tends to be over bony areas, non-fleshy areas, and whether it's got something to do with the rubbing, trauma, pressure, something like that, I don't know, but somebody mentioned the Koebner phenomenon earlier on, whether that's partly to do with the elbows and these stories. I'm not quite sure I really know, to be honest with you, but it's often quoted as that. They tend to be those same sites tend to be the ones that are most resistant to treatment as well. So you have to try harder to get it away from those. Do you agree with that?
Yeah, I don't. Yeah, I'm glad you answered it, 'cause I don't know very well the question. People, I mean, obviously, the bugs on your skin, the distribution is
Yeah.
different as well. But then, is that just a consequence of
Yeah.
something more fundamental? I don't. I don't know. It's interesting.
Well, we do
I mean,
know,
it does a bit vary as well on your ancestry as well, your skin
Oh.
type, because you can.
That's true.
So it's not. So it's an important question and to be answered.
Speaking on the ancestry front, psoriasis, we work in a very ethnically diverse area. So we obviously see psoriasis in lots of different skin tones. But typically, I mean, this is something that's been highlighted a lot, is that images of psoriasis tend to be of people with lighter skin tones. What are the things that you would comment about psoriasis in darker skin tones from your clinical experience of looking after?
Well, I think it's underappreciated.
Yeah.
Firstly, because the redness is not quite so. So I think yeah. We know from evidence, in fact, that clinicians don't recognise the severity of psoriasis in darker skins because of the redness isn't there, and it also can be very challenging to treat. Actually, in certain skin type. Would you agree with that?
Yeah, I mean, Baby, you make a very important point. I mean, the first, well, there are so many aspects about it that's really, really challenging.
Yeah.
The first one is, we talked earlier on about how would give me a clinical description of what psoriasis looks like, and that applies to white skin.
People, yeah.
If you've got black skin, the redness is much more difficult and less apparent. So it starts by looking different. That's the first thing. Secondly, it's likely that what was I going to say? Secondly, it's true from the registry data, I think, that outcomes in certain ethnic groups is nowhere near as good as
That's true, yeah.
in white Caucasians or white skin. And exactly why that is, we really don't know. But most clinical trials are mostly in white skin, where other ethnic groups are included, but it's not reported separately often in clinical trials, is it?
No.
So again, going back, there's this data there that we don't know. It's a big challenge, and why people don't respond so well, I don't know. Again, we don't know whether that may even be a genetic thing. It may be as simple as that.
Yeah, and I mean, actually, when we did the PK work, the drug level work, also there are differences as well in terms of PK handling of the drugs seems to be different as well. But I think again there are global efforts to improve the representation of non-white white ancestry.
Yeah.
Because it's lots of unanswered questions.
Yeah.
Another angle on it is that we talked earlier on about pustular forms of psoriasis. And there's one horrible form of pustular psoriasis called generalized pustular psoriasis, GPP. And there's been a huge advance in the treatment of that rare disease. But we talk about it in the UK as being very, very rare. But it appears to be about 10 times more frequent in other parts of the world. For instance, in the Far East and Asia Pacific area. And so you can't talk about psoriasis as a whole in terms of prevalence, clinical features, or whatever, because it's different wherever you look.
So there's ethnic variation in probably the underlying mechanisms driving psoriasis and the
Yes,
phenotypes that we see.
I think there probably are. Again, the main genetic risk factor for plaque psoriasis
Yeah.
is HLA, what used to be called HLA-CW6, now
Yeah.
called HLA-C0602, and that is much more prevalent in Northern Europe
Yeah.
than it is in Indochina.
Yeah.
And so that might explain why the prevalence of psoriasis, plaque psoriasis, is less there. But the prevalence of mutations that cause this disease, GPP,
Yeah.
are probably higher in that part of the world than they are in this part of the world.
Mm.
So
Yeah.
there is rationale in there somewhere.
Yeah.
So, Catherine, if there was one key message that you wanted patients with psoriasis to know about, what would it be?
There are very good treatments for psoriasis, so you do not have to live with the burden of psoriasis. But it's difficult sometimes to access the right care, so just push for it.
And Jonathan, do you have a message for patients or clinicians that
Well, for patients, I completely echo what Catherine said, as we have wonderful treatments, and you do not need to live with the burden of psoriasis like people used to have to do. For clinicians, I think we need to sort of come up with better pathways of getting patients who need urgent care more urgently. And I think that we need to work together to produce some of these answers these algorithmic answers that we want for personalized care. We're all going to have to do that together. One group can't do that
That's
alone.
true.
It requires clinicians, scientists, everybody getting together. The UK is a great place to do that because we work together better than anywhere else does.
Yeah, absolutely. So thank you very much, both of you, for joining us today. We've looked at sort of the evolution of psoriasis care from your sort of early careers and where it's brought us today. And I think that we are going through a really exciting time at the moment. We have lots of different treatments available, and really we just need to focus on how we can better deliver it to patients. So yeah, I think there's lots of fantastic work going on. So thank you for talking to us.
Thank you.
Thank you.
Yeah, it was a
Thank you.
pleasure.
So if you've made it this far, thank you very much for listening to Skin Conversations, and stay tuned for many more episodes where we talk everything about skin.